the sort of ongoing issue of record is the review of the subject matter pertinent to autism spectrum disorder, which Dr. Red very diligently and meticulously went through with expert opinion rendered by Dr. Deb Bilder at our last meeting, and the renewed narrative, as well as findings from the literature review, have been now sent to Dr. Bilder for her comments. I haven't seen anything come back. And Reshma, have you seen anything come back from Dr. Bilder as of yet?
Unfortunately not.
All right. She may, who knows, she may be on vacation. If we maybe send out a little reminder to her, but there's no great urgency to this. I think, everybody has sort of seen this. It's just a really beautifully constructed document, and it creates, with each one of these, we seem to be getting better and better and improving our role in meeting our obligations as reviewers of peer-reviewed literature, IRB approved research studies, and so on. So again, I think a big group hug, a virtual group hug to Dr. Red for his extraordinary efforts, and we'll wait to get Dr. Bilder's comments with a likely vote to either approve after perhaps some additional comments as the rest of this month goes on. So we'll put that on the agenda for May as a likely motion for approval at that time. Let's see. With that, if there's anybody does anybody want to comment on or any thoughtful additions to the autism spectrum disorder document? Welcome to entertain any additional thoughts at this time. We've got plenty of time to, there's never really a rush for any of these. It's just, I don't want them to, now while we're waiting for people to ponder on that, Dr. Carlson did review PTSD a few months ago, and we're waiting to see if there was any additional input to that. There is no requirement for a certain number of individuals to weigh in. It's just simply a board and group activity, if you will. And just want to make sure everybody does have opportunity to weigh in. Reshma, correct me if I'm wrong, but that updated document and narrative that will go into our guidance, as well as a formal board approval of our conclusions, still is pending. Is that correct, or am I forgetting something?
Yes, for PTSD it is. Just a general way that I deal with it is anytime we have a presentation from a board member or an outside expert on a topic, I'll initiate that we update the guidance document. And then, just like you said, we have no limit on how many people can review it or edit it. And then it will go up on our website. And I've mentioned in the past that we had 2 states looking at our guidance documents and somewhat linking to our state's website for those guidance documents. And that's why it's such a kind of a necessary item to keep those updates, because other states are looking at them and they are being used. And if you do visit our website, we've kind of revamped it so that those documents are easier to see and to know what the board is talking about, who they've had come and do an expert presentation on as well. So that was a long answer to your question, but yes.
Well, rather have too much than too little. Thank you. So I think what we'll do is we'll put that as well on the agenda for May for a final approval, so that we get that documented and of record. And, this serves a number of purposes, as Reshma stated, including our fiduciary obligation to report to the interim Health and Human Services Committee in the fall prior to the legislative session. So we've got plenty of time before that. But it's certainly good to make sure we're dotting our I's and crossing our T's. So when that meeting does come up, time sneaks up on us, and that will allow us to have a comprehensive report. And I anticipate actually a very robust report for this next fall with all the work that we as a board and you all have been doing with regards to these various both approved and non-approved conditions we've been reviewing. A couple little additional items, since we do have plenty of time before we get to sort of the agenda for the next couple months with regards to reviews. There was a web conference presented by the American Psychiatric Association, working with the American Society of Addiction Medicine last Thursday, with a second component of this program for this coming Thursday. I think Katie Carlson, I saw were on the had registered for it. It was discussing in detail with experts around the country, very highly qualified members of the psychiatric community and academic community around the country, who have a special interest in substance use disorder and addiction medicine, to review that literature pursuant to psychiatric conditions, mood disorders, and those sorts of potential indications for the use of cannabinoids and cannabis as medicine, as well as the potential risks, especially the risks of use disorder. It was a very well attended and very well thought through conference. I've got some notes from that I can share perhaps at a later date, but I think maybe since Dr. Carlson is one of our two resident psychiatrists, Dr. Crookston, our other, maybe I'll defer to her, and maybe she can weigh in for a few minutes when she comes back online, unless we've already concluded our meeting in the next 10 minutes. But that was very worthwhile, and I think is a sort of a complement or supplement, if you will, to the work we're doing. I've also been invited to present at the Addictions Conference that the University of Utah Department of Psychiatry hosts on an annual basis. It's coming up in June, and I've been asked to present sort of the ongoing work of our board and to summarize the findings from our board. Of course, not much of it has to do with substance use disorder per se, other than, of course, the opioid use disorder subject matter that we dealt with a few months ago. But I think for their overall interests. Oh, Ed, could you put yourself on mute, please?
Who's this?
Oh, he's off the phone anyway. Don't want to embarrass our esteemed colleague there.
Sorry, man.
Go ahead and mute Ed anyway, just because get a little less feedback.
I was muted.
No worries. Anyway, so I'm going to be presenting our material. It'll be pretty dry. It's really a rundown of our findings and conclusions. But I think for those in the interested in the larger subject matter, it helps balance benefits and burdens as they think about cannabis with the intention to use for therapeutic purposes and the potential risks. So that will be, I think, June 6th, and that'll be a virtual conference. I don't believe don't know if there's any charge. I don't think there is a charge to register, but Reshma maybe can check that out. And I think it would be delightful if board members could participate, as well as our administrative leadership from the Department of Health, because these are questions I know that oftentimes are referred to those of us who are somewhat or even tangentially involved in all this. Any other sort of news items along those lines? by anybody on the board or Department of Health? You've got a little time today to catch up on sort of a rapidly moving field as we.
Harry, on that meeting in June, can you clarify maybe at some future point what day and time that is so we can put it on our calendars?
Yeah, Ed, it's June 4th through 6th. I think it's a 3-day. Let me double check. Yeah, it's I'm sorry. I think it's actually the 2nd through the 4th. So that's a Wednesday through a Friday. It's going to be broadcast from the Marriott University Park Hotel, but it's going to be a virtual conference. But I think the speakers are going to be coming from there. I haven't had a final notification of that. A lot of the speakers will be familiar to you, people like Adam Gordon from the University in the PARCA program and others. But there's also some very noteworthy national leaders in the area of substance use disorders, and some of it, of course, applies to cannabis and cannabis use. So I think I'll try and get, excuse me, the notification information to Reshma so she can distribute it.
Okay, thanks.
Thanks. The only other sort of item of interest and that maybe Rich and Sarah want to sort of talk about a bit is we've been having some discussions, ongoing discussions, and Reshma too, of course. Reshma, you're sort of the always included. You're sort of the glue that holds us together. Discussions about research and further defining and supporting the role that we as a board play, both in name, but in title, but also in actuality. And there's a little bit of, as in our discussions, sort of leadership level, sort of a realization, and so with some input from the board as well, that board members, that the intention of forming the board a few years ago, before the program actually got up and running, was to sort of create some baseline information and educational materials, and to at least prepare something that providers out in the community as well as the public could have some access to some basic common language and understanding of where we stand with regards to research evidence and publications that have gone through peer review with regards to cannabis as medicine. It turns out perhaps the name Cannabinoid Product Board is not as apt as it needs to be, because we really don't have much to do with products that are being sold through the specialty pharmacies now that have been established. We're really more of a generic evidence-based research and review group, and that's what our charge has been. So as the formative years have taken on and things have evolved, we're sort of in discussion about how we can create less confusion about what we do and how we do it, and some of this discussion will perhaps go back to some of our legislative leaders for those things that do require maybe some tweaks. So Rich and Sarah very actively involved in those discussions, but also with regards to research and reaching out to colleagues at the University of Utah who may have some resources that we simply don't have at the moment, but are very interested in intermediary and outcomes with regards to cannabis use as medicine, both on the therapeutic and the risk side. Senator Vickers, who's really sort of been a senior leader in the legislature with regards to an interest in making the program in Utah as scientific and clinically not only robust, but also valid as possible, to be a real leader in the country in doing this, is interested and has expressed interest as we've reached out to him to meet with us, sort of the leadership at the university research group, as well as Rich and Sarah and just myself, sort of representing Department of Health and our board, just to have some initial discussions about where and how the legislature might see this going forward with regards to making our work a little more robust and supported with resources and any specific directions they want to go. So we've got some meetings that are being set up in the month of May. I think it's May that we've found a date we can all get together. And so we'll have more to share, maybe not the next meeting, but perhaps by June. But Rich and Sarah, would you like to sort of amplify or compliment or correct anything that I may have said that's not quite on track?
Yeah, so Perry, again, Sarah Wilsey, I'm new division director for family health preparedness and working with Perry, Rich, Reshma on our cannabis program. I think the thought would be, hey, this program is up and running. You know, due to the structures of the system, we have a contained set of data around cannabis sales, cannabis diagnoses, et cetera. What are the opportunities with those databases? And I think it's worth thinking about things we can do. We know there's limits with all data collection, all, you know, privacy security issues, but what can we do? So I think the discussion with the researchers is, you know, what do we have and what would we want to try to build to look at that and to complement with other data systems that the Department of Health has. So just looking for that bigger vision of this as a public health program that we'd like to see best outcomes or learn more about what happens with the medical, medical delivery of cannabis to patients. Rich, do you want to add anything?
Sure. So some of my thoughts are, I think there's a difference between a survey that I think was helpful that we did of patients that Reshma led as we got some ideas from patients about their experience in the program, and that was certainly helpful, and we published that survey. And something that would be more scientific and I think more informative to the scientific study and could be used not just in Utah but in other states as something that could guide treatment for a particular type of condition. So we're hopeful that there will be some researchers in the future that with approval from an institutional review board, an IRB, would do some scientific research, and it may require reaching, or they could be approved potentially to reach out to patients in an appropriate way. But it may be that they don't need to reach out to patients. They could just use data that's been collected in our system that's kept confidential. They wouldn't even have to be identified, the patient group, and that they would be approved to use that data to then move forward and publish something that would be, I think, informative to the community and in academics, but also to the industry. So those are some thoughts that Dr. Woolsey and I have talked about. And that's, I think, a way that we could move forward, and we could certainly benefit from some of the insights from board members in that respect as we move forward with that, I think, long-term goal of seeing some of those type of studies done.
Rich, I think the other thing, Perry, you and I've talked about is, just what kind of staff would support the cannabis program, and exploring the types of staff we add to this program that really augment the medical mission. This literature is emerging. And I know, Perry, we've talked about, that sort of pharmacy aspect of the literature is just emerging all the time. And so I think that's another thing to talk about is, as our center grows, what kind of expertise would be helpful? So that's another thing Rich and I have been talking about, Senator Vickers as a pharmacist, potential support there. So these are a couple of things we're talking about in sort of the vision of the next couple of years. I appreciate the interest, Perry.
Thank you very much, Sarah and Rich. And also, you just remind me that we do have just let the board know, Rich, Sarah, Rich, myself also have a meeting being set up with the head of pharmacy services from Intermountain Health. They have developed some programmatic plans there that, and of course, as a very large healthcare provider in the state and thought leaders, we very much want to be on track and know what they are thinking and doing And so we're going to pick their brains a bit and see as well how we can collaborate on a knowledge-based level. I certainly see PharmDs as being just a tremendously rich resource of knowledge, skill, capabilities in advancing our sort of mandate going forward. So we're going to try and reach out to additional colleagues, whether they're on the board or sort of helping in ancillary ways. We'll do what we can. And with that, I want to appreciate Karen Wilcox's contribution here in the chat. Everybody can see the link, and Reshma, I guess, will send that out as well to everybody. And Karen, just to prove the adage that no good deed goes unpunished, I want to pick on this weary face. When an anesthesiologist comes at you with a big syringe, you should.
What's in the syringe?
not just a mask. So as I spread a little ether here, Karen, you had we'd been in contact a little while back. We'd gotten some questions about the use of cannabis products potentially for certain individuals who simply the GI route, pulmonary route simply are not available or acceptable. Perhaps as a rectal route is consideration. And we were hoping that maybe somebody from the College of Pharmacy at the U might be in a position to do a little research and dig into that and give a bit of a presentation. I just didn't want to drop that drop off the radar before we lose you in the next couple months. Reminding everybody that Dr. Crookston and Dr. Wilcox will be sailing into the sunset, not on an ice flow, but hopefully
there are none left. No ice flows in which to sail off.
just because you fulfilled your duties here, your life is beginning, not ending, actually. So, but anyway, before we lose you, I just wanted to check in on that. And
Sure.
Is there anybody who might be available to give us a bit of a presentation on that in the next few months?
Yeah, I'm happy to give it a whirl. It's my parting shot over the bow.
Right.
I frankly don't know a lot about it in terms of products or currently, but perhaps there's some starting to be developed. I don't know. Certainly for those of you who don't know, there are many applications of many different drugs used as suppositories, especially in emergency situations. So when people aren't able to swallow, so if they're in status epilepticus and having seizures, you can administer rectal diastat to help stop the seizure activity and things of that nature. So it's not an unusual route of administration, especially for those who are in a situation where they're unable to swallow or to take oral drugs. So happy to see what's out there. I will put it on my things to do. It's best if I have a deadline.
But I tell you what, let's make this your parting shot. How about June? And
Okay,
that way, after you don't have to be accountable for anything because you'll be
I'll be out of here.
you won't be able to,
sure.
A little political tricksterism. Anyway, yeah, I think it would be very helpful for the board. Just a quick review of essentially pharmacokinetics. What happens when a pharmacologically active drug is administered rectally. What do we know about absorption, uptake, and some of the limitations because of issues around body cavities being filled with other things other than drugs. So
Sure.
maybe a bit of brief review of that, and then how that folds into what we know about the pharmacology of cannabinoids in terms of their lipophilicity and absorption characteristics and so forth. I suspect most of the products that be cannabis based would be ad hoc or specially formulated at this point. But there might be some literature that you might be able to find. And then when we have that presentation, I think some discussion and weighing in by our, if you will, our resident pharmacists would be helpful to know what they're thinking and what kind of requests they're getting. And so we'll defer that discussion till June and put that on the agenda. And Karen, thank you.
Sure. No worries.
I thought you were going to get off scot-free, and just to show how much equity. The Dr. Crooks. Mike Crookson is still on. I'm going to ask Dr. Crookson just to review, just so we have one more additional board member Mike, if you could just over the next month or few weeks, just review the sort of the findings that Dr. Carlson came up with, and just make sure there's nothing that has come your way that is in flagrant, disagreement, or just any thoughts you might have, and just if you'd weigh in on that, and then we'll take full advantage of your psychiatric expertise and Dr. Wilcox's pharmacological expertise, and then send you packing. Okay. With
You'll
that,
always know where to find us, though.
I've been treading water here, waiting for Dr. Carlson to sign on, so she could maybe give us a few tips from that conference. I don't see her yet. So the only thing left on our agenda is to discuss other upcoming reviews. Reshma, if you would please share with us sort of how you tracked down Dr. Puckett, Megan Puckett, and her expertise in dementia and Alzheimer's particularly, and her willingness to give a review for us in a presentation at the May meeting.
Yeah, we at the Department of Health have a division for healthy aging, and a few names came to me that were highly recommended from colleagues on just good presenters, good speakers, and eventually those names highly recommended Dr. Puckett, who will be presenting on Alzheimer's and dementia in May. And she does have experience with not just research in using cannabinoids for Alzheimer's, but she also has patients who are using it. So she'll be a great addition to our expert opinions that we've collected so far.
Fantastic. And, we're sort of harrowing the fields to find expertise in various areas, so that, one of my sort of goals as the chair for this year was to really fulfill or maintain the momentum, I guess I should say, to get through as many of the approved indications, as well as to hear from the Compassionate Use Board if there are any special requests that come through in terms of review of non-approved or issues that might pertain, say, to the pediatric population or others, so that over the course of the next say 6 months, we can get through at least 3 or 4, and maybe even half a dozen subject matter areas, and make 2021 a real banner year for doing these. With that in mind, a colleague of mine from the Division of Pain Medicine, who is also part of the Huntsman Cancer Institute's supportive oncology group, the palliative care group there, has agreed to do a deep dive, one of our deep dives in cancer pain as a indication for cannabis products. And so that's Dr. Dan Odell, and he's going to present hopefully in June. He'll have is committed to that as a deadline. If somehow he gets hung up, we'll just postpone it. But that'll at least give us 2 more subject matter areas under our belt by the time we get to our sort of refreshed board with new additions starting in July. And as we get them, that's our sort of we sort of follow an academic year, I guess, rather than a calendar year in that sense. We have some very highly qualified individuals that have been nominated and are going through the Utah Medical Association review process. Ed, do I have your permission to speak on your behalf about your extraordinary volunteerism? I love to embarrass you for all. The only people I ever try to embarrass are people I have just immense respect for, and you're one of them. So Ed, if there's any, speak now or forever hold your peace.
Well, there's just one thing I wanted to mention. I still think one thing that really in my mind is important is that we understand as much as we can about one indication that's on the, one of the qualifying conditions is treatment of epilepsy or seizure disorders. And I think it's really important for qualified medical providers to understand the potential benefits, risks, and also as much detail as we can give them based on the literature anyway, and based on expertise from neurologists about, about how cannabinoids might be used for treatment of refractory epilepsy or even in children. I think that the Compassionate Use Board is faced with these questions a lot, and we're going to be seeing more of these, I think, as time goes on, about people who are under the age of 21 who have epilepsy and might and are asking to be able to use cannabinoid products, whether they're THC, high cannabidiol content with a small amount of THC or whatever it is. My concern is I don't think. I think we really use some expertise on that area, because that's one area of all the ones I worry about. That's the one area I worry about the most, because of the potential for either good or bad outcomes depending on what happens. And I just feel really uncomfortable about that particular indication because of the risks involved.
Ed, you had signaled that you might have a contact in the sort of epileptology group or individuals at the U. Did you?
I don't think I don't know anybody. Well, no, and that's not true. We do have. That's true. Let me look into that some more. Let me say. Let me try and look into that some more.
Okay. I just want to. I didn't want to make sure I wasn't making that up.
No, let me look into that some more and see what I can figure out. But I think we should probably make that happen sometime. Hopefully in the next 3 or 4 months. Yeah,
if you can just give names to some names of interest to Reshma, she's become really just beautifully skilled at
work on that.
Not twisting arms so much, but as gently coaxing people into and I'm still working on my skill set, but Reshma's got the letter down, and she knows what to do. So if you can provide some names to her. Katie, I'm going to call on you in a second as you warm up here.
Harry, it looks like Kevin raised his hand.
Yeah, that's what I was. I was going to, before as Katie's warming up her electrons. I was going to call on Kevin Baumgartner. Has been very patient with his hand raised. Kevin, please. The floor is yours.
Thank you, Dr. Fine. I just wanted to circle back slightly to where you were mentioning, PharmDs being a good asset and getting cooperation there. Just know that us as the cannabis pharmacists and the Cannabis Pharmacists Association, we're here for you guys. We want to see this program succeed. We're dedicated to the care of the patients, not necessarily just selling as much cannabis as we can. So just know that we're here as an asset. Any way you can use us and want to use us, we're here for the patients. So just know we're here for you.
Rich, I'm going to ask you to comment. We do appreciate that fully, and especially your guys' ongoing participation and engagement in our meetings. With that in mind, the Utah, is it the Patient Cannabis Advocacy Group, and I'm blanking on the official name, but also the Pharmacy Association. I think Rich has been sort of engaged in trying to figure out how we can best take advantage of that to inform ourselves as a board about in objective a manner as possible, and to make sure that we have sort of firewalls with regards to conflicts of interest and those kind of things that we have to do within the Department of Health and our legislative mandate. So Rich, do you want to please weigh in on that?
Yeah, so one thing that we plan on doing, and I haven't spoken to the Utah Cannabis Association about this yet, so Molly Davis, it looks like Molly's on the call right now, but she's the executive director of the Utah Cannabis Association, so she represents some of the medical cannabis pharmacies that hold licenses that employ pharmacists, but also processors and cultivators that are licensed to grow cannabis in the state. And one thing that we thought would be good is to schedule a time, probably in late July or August, when we would have some time specifically with members of the Utah Cannabis Association, which includes pharmacists and some scientists that work for those processors and cultivators. And they would just have an opportunity to share general information about the various products that they have and some of the things that they're learning based upon patient experiences with those products. And that way, the Cannabinoid Product Board and some other individuals that at the Department of Health hold some responsibility over cannabis could have the opportunity to learn about some of those operations that they have going. And we feel like that was just a request I was going to make of the Utah Cannabis Association to see if they could host something like that. And I hate to put you on the spot, Molly, but does that seem like something that members of your association would be willing to do?
Unfortunately, I got cut off for a couple minutes right in the middle, so I kind of missed what you were saying. Sorry.
Oh, okay. And I've got some drilling going on in my background, but what I wanted to know is if the Utah Cannabis Association would host a virtual event where you would have some of your members, some of the pharmacists that are members, and also some of the processors and representatives of cultivators, where we would have the opportunity as a board and as a department to learn about some of the general products that some of your members sell and make available to the card holders. And it would be an opportunity for them to share some of their experiences as various patients have used those products. So this would be something that we'd schedule for late July or early August when we have new members of the Cannabinoid Product Board appointed.
Yeah, that'd be great. I'd love to do something like that. Anything we can do to help provide information for you guys, even if you, virtual event would be great, but we could even do like an in-person event, bring you through a pharmacy, show you the patient experience, let you touch and feel the products like in your hands, maybe talk to patients. We would love to set up an event like that.
Yeah. So anyway, I'll be coordinating with Molly and other members of the Utah Cannabis Association on that, and that would include pharmacists. So I'm glad Kevin brought that up. I think that would be a good connection to make this summer, is to schedule a time for that. I think that would help on both sides as we move forward in the program.
So just question, this Ed Red, would that be one of these meetings, or would it be a separate meeting, or how would that work exactly?
I think it's a separate meeting. I anticipate that it wouldn't be a public meeting. It would just be by invitation of some specific pharmacists in the association, and also some specific representatives of processors. They've got some people with scientific approaches to what they do, and I feel like that would be the most helpful to members of the board and to employees of the department. I've had these visits, but there are, I think, some individuals that would benefit in our department from that type of a meeting. So yeah, that's what it would be, and it would be by invitation to members of the Cannabinoid Product Board. We would invite all members of the Cannabinoid Product Board to participate, potentially members of the Compassionate Use Board as well.
So I think the Compassionate Use Board would be really good to be part of that too, if we could. The other thing we might want to do is through our discussions in this board over the last several years, there's been, the Department of Health, because of the way the law is written, we just focus on cannabidiol and THC as far as what we're doing is in the medical cannabis program in Utah. But there's other cannabinoids that some of the pharmacists that are participating in these meetings have brought up, like THC8 and cannabivarin. I can't pronounce it. CBDV. And there's some other things. There's some other minor cannabinoids that they've been talking about in some of these meetings that I think it'd be interesting to have some of their pharmacists discuss during this meeting that we're having. Things that we may not be familiar with or understand what's going on in their situation. That'd be interesting to me anyway, as part of this meeting.
Yeah.
Yeah.
Absolutely. So we'll put together an agenda and with your help and with help from the industry. And so I'll get working on that so we can schedule something, and so you can schedule it in your calendar far ahead. And so some members of the association can prepare in advance. And I think that would make it really beneficial. So it wouldn't be a public meeting, it would just be a meeting for by invitation. I think that would help the discussion be open, and so we can all learn from each other as a group.
All right,
Great.
great. That'd be awesome. I think it'd be really interesting because there's a lot of things that there are a lot of things that they're kind of working on their own, just talking to them.
Yeah.
That we don't really discuss a lot here, and it might be interesting to see what what they're working on and things they're talking about. For example, there's one other thing that's interesting to me is the effects of when you process cannabis, you have the plant actually has THCA, and when you heat it up, it changes the THC, for example, and some people are promoting the use of THCA or CBDA or other cannabinoids that haven't gone through that cooking process as interventions. And I don't have any literature to help me with any of that sort of thing, but I think it's really interesting what they've talked to me about. I think we just need to maybe have a more open discussion with them about these other things that they've seen. I don't know. It's just my gut impression. Just
Well, Ed, I think what you're pushing towards is sort of a state of the science with regards to cannabinoid chemistry and our understanding of clinical effects, which, as you know, is still very, very limited and still under great debate about what are really active and inactive products. So anyway, the program that Rich is really talking about is one of just really familiarizing the group, the board, regardless of what our ultimate name might be, to really understand what is fully featured components of the program, and what the Center for Medical Cannabis is really responsible for, from growth to production to extraction to processing and ultimately to the kinds of products that are out there and how they are how the various components are measured. Right now it's just THC and CBD, and how to the extent how assured we can be, and qualified and limited providers as well as the public can be, that what they're getting is what they're saying, what you see is what you get, and so forth. So
Yeah.
we need to understand that.
Okay.
We also, but it's really sort of in a way a separate issue, is what is the burgeoning science, because we're not measuring any of these other components, and the understanding is very important to understand what these other components are. And yet, and so that's where we're really going to be intersecting with, what active role can we take, and the state help us take with any kind of research arm, not just from a data gathering and an improved data gathering database, but can we in fact start measuring other components? Do we have the science to do that? Do we have the funding to do that? Will we be able to understand outcomes better if we do this? These are all open questions. This board is really not yet prepared to enter into a deep dive with regards to those issues, but I think that we do need to be informed. And so I think after that work is done, and Rich coordinates this with Molly, and we participate, I think the next level of thinking I'd like to do in working with this group, and once we get our new board members and think about what areas of expertise, especially in the area of applied pharmacy and pharmaceutical development and pharmacology, is looking at that kind of level of science and limitations from people who are actually involved in that as a discipline with real expertise, as well as, and I say this again, not in a manner to disparage anybody or anything, but we really need to maintain really strong firewalls, I believe, with this group, and our legislative charge with any conflicts of interest whatsoever that have to do with any implied commercialism. And Kevin, I really appreciate your sensitivity to that. And those on the phone call, we know that you have a great deal of integrity. It's just that we have to sort of, in a way, practice what we preach and create those firewalls. So with that said, I want to move towards welcoming Dr. Carlson onto the call. Thank you, Katie, for joining. I know you had a busy morning and appreciate your coming on. I had signaled to the group that you and I had both participated in the first half of the American Psychiatric Association's conference of national leadership, talking about psychiatric implications and cognitive implications, others related, issues with regards to cannabis. And I said that, there were some real key points that came across that I think sort of supplement or complement the work we're doing. And I wanted to, pardon me, if you would mind just sort of, excuse me, I apologize, taking a moment or two to sort of review your takeaways from that conference, as last Thursday it was.
Yeah, thanks, Perry. I think the biggest takeaway is really that there is a lot more expertise from the scientific community and from the from physician groups than there was even a year ago. Certainly since this group was formed 2 years ago. And I think that is where we want to be aligning ourselves. So this group was a team of physicians who have been studying cannabis, using cannabis in some cases in their patients for a very long time, and have a lot of knowledge about the limitations and the realistic expectations that in terms of where we're at right now. I know there's a lot of hopefulness, a lot of ideas, a lot of information generated from a variety of sources, but I would urge all of us actually to do part 2, which is Thursday, and to go back and do part 1 when you have time, because, and Perry, I don't know if you agree, but I was really impressed. I went to the other webinar that Reshma had mentioned, was several weeks ago. To be frank, it was completely useless. There was nothing helpful or new, and it felt almost more like a trade show. And so I went to this one with kind of muted expectations, but that's one of my biggest takeaways. The other is, I guess there are 3. The other is we've done pretty well. I mean, I think there's so much room for improvement in how we kind of set our agenda and how we gather our information, and then how we communicate to the public about what we're doing. But, we have some of the recommendations that they have in terms of for a board like ours is we've done a very decent job, and I was glad to hear that. Again, room for improvement. And then I don't know, Perry, if you wanted me to get into any of the nitty gritty, but in terms of various diagnoses and kind of downsides of things that happen, or maybe some positive things that happen, I'm happy to share
Sure.
some of. Okay.
Yeah, we do have a few minutes, and I think it was people might not have time to go back on Thursday. This coming Thursday, I'm going to be unbelievably, I'm going to actually be on an airplane for the first time in a while, so I'm going to miss that. I'll hopefully go back, but it certainly struck me as you were sort of intoning, Katie, that a lot of the subject matter that we'd reviewed and a lot of the conclusions we'd come to with regards to risk versus benefits, and certainly the larger overview that there's evidence of tremendous interest in cannabis as medicine for various and variety of indications. But that interest greatly exceeds the levels of evidence that exists right now for specific populations and therapeutic benefit, with the exception of some of the unusual pediatric and rare, fortunately, epilepsy conditions for which there is one FDA-approved product. But in terms of cannabis, whole cannabis or extracts, most really we're going on a combination of sort of best judgment, safety over excessive, trying to minimize over promising and under delivering and so forth. With regards to our recommendations with regards to THC CBD ratios and different conditions. But the absolute evidence in controlled trials with specific populations that you can then generalize from, which is what science is, unfortunately is very limited. We know a lot about the pharmacology that we don't often talk about, and this was to your point, Ed, that is in development, but how that pertains to actual clinical, real patients in real clinical circumstances, and especially over the long term for chronic conditions, is mostly a big question mark. Most of the data that exists from what my takeaway from the meeting was that there's a lot of aspirational stuff with regards to cannabidiol, a lot of disappointment, at least with regards to THC, in view of the potential risks outweighing potential benefits. And so, Katie, I would appreciate it if you had any other further generalizations or conclusions that you came from that, but especially if there's any real positives that you noted.
Yeah, and so I'll be brief. I'll say I'm a psychiatrist by training and an addiction specialist. And I was happy to hear that there's very good evidence that use of cannabis in a population that doesn't already have mental illness and mood disorder, anxiety disorder, certainly psychotic disorder, does not increase the incidence of anxiety disorders. So if you have that rare patient, again, I'm a psychiatrist, I don't see these patients, that has no history of anxiety mood disorder, and they were to try cannabis for some condition, it's unlikely that they would develop an anxiety disorder. And that is positive. I think the kind of flip side of that is providers have to be incredibly meticulous and certain that their patient doesn't have a pre-existing anxiety disorder or mood disorder, certainly psychosis. I think that's well established. And I'm not convinced that we're very good at picking those up in our, the way our encounters are set up, in a one-time encounter. And I could spend a lot of time in that in terms of how anxiety presents and how patients kind of convey what their symptoms are, along with complications like it's hard to distinguish between anxiety and substance use. A lot of symptoms, including cannabis use. The kind of the withdrawal from cannabis can create some symptoms that mimic anxiety. But one of the things that really I must have stood out, because I took notes on this, that there's been a 97% increase of use in cannabis for patients who have mental illness. That's profound. And that's in the COVID year. So in the past year, there has been a 38% increase in the amount of cannabis used in this past year. And there's been a 68% increase in the number of people who are high each day for 6 hours or more. And you know, as an addiction specialist, what that tells me is we're seeing an increase in the development of cannabis use disorders, because cannabis is addicting and regular use does lead to a dependence and some withdrawal symptoms, which does not equal addiction, but in many cases, especially for younger brains, it does. And that creates a whole new set of unintended consequences of this kind of wider distribution and wider acceptance of cannabis. And then finally, I'll end with what I thought was good news, but patients who discontinue cannabis will experience a decrease in anxiety symptoms. And they've studied that in various ways, but along with that is a decrease in use of anti-anxiety medications. So I'll stop there. There was a lot of other talk about how cannabis and the cytochrome system that's involved in metabolism leads to a lot of drug interactions. I think we've covered that fairly well, but that seemed to stick out. But so that's kind of what I took away in this part one, and I'd be happy to do a better job. I didn't really come prepared, but I'm happy to try to summarize what I learned on Thursday. I do plan on attending that, and I'll share with anyone who's interested what I learned.
You know, I think it would be a good idea, especially after the addictions conference in June, to maybe try and package what we've learned without having to do our own separate review. I mean, in some ways, others have done all this work for us, and these are very thoughtful researchers. And also, maybe Katie, since you're going to be continuing on with us into the new sort of academic year, fiscal year with this, maybe we'll look forward to maybe a more packaged, just a review of cannabis use disorder, propensities, demographics, benefits, risks, and so forth in maybe August, September, something like that. Not take the heat off you a little bit. Any questions? You know, there were a couple of other points that actually, as you were talking, Katie, I was looking at my notes. You know, couple of really outstanding things I thought that struck me was the you know, the drug interactions are not trivial whatsoever, and we have and continue to think about those as we give our presentations. As we start looking towards higher dose cannabidiol delivery, especially very high CBD, potentially very low THC or no THC whatsoever, we're going to end up seeing different pharmacodynamic effects. One of which actually, which is probably the leading concern for long-term use, is liver toxicity, which, you know, when I started looking at, you know, 10 years ago, was looking into the CBD literature, that wasn't even a discussion point. Now it's becoming more of a concern. So we'll have to keep our eye on that, because that may in fact become the leading edge of some of the you know, the products in development will be much higher CBD doses that people are getting, and delivery systems that are much more efficient because of bioavailability issues that are now becoming overcome and so on. So that was I think, you know, a couple of important takeaways as well. The other point that was made, I think sort of repeatedly, and we're all familiar with this, but I think it bears repetition, is the extraordinary changes that have occurred in our lifetimes, from my growing up in the 1950s and 60s, and the kind of cannabis that was available in the 50s, 60s, 70s, and even through the 80s, and the kind of cannabis products, the chemovars and the development of strains that are extraordinarily high in THC, and some obviously the kind of products that then emerge from that. And the other point I think that was made was that smoking and vaping are two very different things. But one of the things that we talk about, vaping is safer for this, that, or the other reason. It's an approved delivery system under the Utah program, but vaping delivers much higher cannabinoids and especially THC levels and active THC levels. The carboxyl, it's decarboxylated to your point in smoking, not so much in vaping, and as well as the delivery is much higher for various reasons. And so the ability of both patients and non-patients to get very high THC levels, which might lead to unroofing, if you will, for lack of a better medical word, of a cognitive disorder, of schizophrenia, of psychosis, is worrisome. And as one of the researchers in this area said, if I'm remembering this correctly, Katie, was that once that toothpaste is out of the tube, it's almost impossible. We don't have good ways of getting it back in. And so we do need better ways of evaluating patients, both in terms of family history as well as genetic predispositions. So personalized medicine and evaluative assessment and so forth going forward may be part of the science that's going to develop too, to reduce some of the risks that are involved, especially in different products that have a lot of THC. Those were other thoughts that came out of this. Katie, did I summarize that correctly? Did I misstate anything?
Hey,
okay.
Can I ask a real quick question? Katie, do you guys have a link? I'm not going to be here this Thursday, and I missed the other one. Is there any way to go back and look at this online, or to do this conference online without actually being there on Thursday? Is that possible?
I believe so. That was my understanding, that you could have access to this. I'll send you all the links. And, they may make it available to our board if we were to request that. I'd be happy to reach out to them if it turns out you can't, Ed, but let's assume that you can, unless Perry knows for certain that's incorrect.
No, I don't have any other info. That'd be great if you could send those links around. There's another, I guess I'm filled with adages today, but another adage that every meeting is perfectly designed to fill exactly the entire amount of time as for which it's been said. And I don't intentionally want to do that. It just turns out there's a lot of sort of loose strains and loose strings of things that we've been able to pull together because we've got the time and we have not been filled up as we have been with other agendas. And as you hear going forward in May, June, et cetera, we really will have very full agendas then. So I'm glad we can take this time. With that, I do have one question actually for, is Dave McKnight still with us? Dave, are you still on board by any chance? What I was hoping to ask Dave from his legal perspective is if there's any light that he can shed with, for instance, I guess it's last month, Virginia became one of the additional states where recreational use is now legal, still, of course, under federal law, but under state law is. And if there's any information that we as a board might benefit from in terms of legal issues that have come up or concerns. One of the, I think, really fascinating questions that I think has great public health import is when states go to recreational as well as medical use, what happens to the medical program? If people, one of the really oft repeated phrases when I was attending some of the legislative sessions and hearings several years ago before the initiative, and when there was people and proponents in Utah were trying to move forward towards a medical program in the state, was that people who want to use cannabis with medical intent should not be viewed as criminals and should not have to move out of state and should not be exposed to to vulnerabilities associated with legal issues in order to meet their health needs. And that's obviously a complex area. But what happens when the, if you will, cover or protections of a medical program are no longer so much necessary if there's also legal use without medical requirement? What happens to the medical program, and does it lose some of the boundaries that are established to maybe help us understand better risks and therapeutic benefits? Do we lose an opportunity to understand and to learn more from that, from the kind of, some would view it as constraints, others would look at it as sort of goal lines and sidelines that a program like ours imposes. So I was wondering if Dave had any insight into that, or if anybody does, anybody, our health department folks, or Ed, you seem to...
So just briefly, I mean, I've looked at other states that have gone down this pathway, and the way they separate the two programs is by taxation. There's a much higher tax on recreational cannabis in the states I'm familiar with, California, if I'm not mistaken. I could be wrong on this because I've been in too many states, Colorado and California, which I'm most familiar with. But if you have a medical card, you don't have to pay as high a tax when you go purchase the cannabis at the dispensary, versus if you're purchasing it just for recreational purposes, you pay a higher tax. And when I say higher tax, I think it's upwards of 33% or 40% or something like that. It's pretty high. And there's all sorts of unintended consequences of this. It drives a lot of people into the medical market to get cheaper cannabis who may be just using it recreationally, and then the other issue is it still promotes a black market. I mean, I have the benefit of having a daughter and son-in-law who live in Humboldt County, California, and the black market in Humboldt County is still very much alive and well because of the whole taxation process in California for taxing legal cannabis. So I don't know exactly how that's all going to pan out. If the federal government decides to legalize recreational use of cannabis, which I suppose could happen, but if it does happen, or when it happens, I'm not sure how that's going to affect us. I have no idea, but I've often asked the same question myself: what's going to happen to this program? What becomes our role under those circumstances as a cannabinoid product board? I still think our job is to provide medical providers who are discussing this with their patients the best information we can to help them provide good information to their patients. That's kind of how I see our role here. But I don't know what will happen. I just know that in other states, people generally do what's in their best interests, what they perceive as is in their best interests. Anyway, that's just been my observations.
Yeah, well, I'm aware that. Yeah, please,
Barry.
Rich.
So I did a little bit of research on this a few months ago, and I'm just bringing up some of that research. There's what's called the Center for Americans for Safe Access. They have a director of government affairs that did an analysis of Oregon's experience in some other states. And his analysis showed that some of the products that patients have relied on for consistency and have used for years are disappearing off the shelves to market products that have wider appeal in a recreational market. So that this is specifically, I think, reporting from Oregon's experience when they went from medical to recreational. So some of the products that were depended on in a medical market simply just weren't available in a recreational market. Also cost. Typically the medical grade products cost more to process. And you pointed out, Ed, that there's not a tax on the medical products, but they do require more, I think, a higher medical grade of testing, and potentially a pharmacist or a medical employee that would be there working at the actual dispensary in that type of a situation. And so Oregon's experience is that they had 2/3 of patients give up their medical cards when they went recreational.
Okay, thanks guys for weighing in on that. I know I did sort of open up a can of worms with that discussion, but this is sort of the evolution of this going forward. And at some point, I think it's predictable that there will be a federal action that will certainly reduce penalties or eliminate criminalization and just create a regulated program nationally or for states to oversee, but won't have federal implications, just like alcohol. But some people thought that was going to be 2 or 3 or 4 years ago. It's still just hanging out there, and who knows if and when. But I think that we have got our hands full with just what we got our hands full with. But I think we should always have a vision towards futuring this, and better to be anticipating than reacting. So with that, certainly open this up to public comment and thought discussion. Really appreciate everybody who stuck through this hour and 20 minutes, a little shorter than the past, but get ready for a good, maybe a little longer session next month. Any discussion from or comments from our other attendees?
If you do have any, you can put them in the chat. We realized our raise your hand function isn't in Zoom, but you can just notify us in the chat or speak out if you do have a comment.
Well, great. Well, thanks one and all for participating, and all those who I pointed to and picked on today. Thanks for your willingness, and none of the work that we do, this is all volunteers for the people on the board. And I just want to remind everybody how appreciated that is. And we could not do what we do without your willingness. As the clock winds down on Karen and Mike, as you have any maybe concluding comments over the next month or two, and things you've learned that you want to share, we'd love to hear your experience. You're always welcome to join in on, and I'm trying to make these meetings starting in July really exciting so that you'll come back and join us. But everybody stay well, take care, and we'll see you next month. And we'll conclude this meeting at 10:23 a.m. Wasatch Standard Time. Bye, everybody.